Thank you for the kind introduction. First of all, good morning to everyone, and I would like to thank Dr. Devi Meenal for having invited to give this session on OSCE, and hope this OSCE session will be useful to all of you. So we have some questions, and rapidly we'll go through, and certain questions you can just throw in your answers. So most of you would have seen this. What is this? Loudly, anyone? I'll just go through it. So it'd be interesting to be a bit interactive so that you can say, what is this called? It's a quench button, right? So what is its significance? Mainly the quench state has two significance. One, if there is a hazard, a patient gets caught inside the magnet and due to the stretcher, you can press the quench button to reduce the helium, which reduces the superconductivity. The other main thing is one should not accidentally press this button. This will lead to loss of helium and leads to huge economic loss even now when the helium is scarce. So this is the main, so this is a quench, and it can be deliberate or it can be accidental, pressing the quench button. And the MR system generally have a vent to pass the helium, and if there is a quench occurring, the helium inside the scan will replace the normal oxygen, and this can cause asphyxia to the patient. So that is the main hazards of pressing the quench button. So this is the next question. What is the sequence? So what does this measure, and what are its types, and what are its advantages and disadvantages? So what is the sequence? Okay. So this is looks like a perfusion weighted image. This is actually a non-contrast perfusion weighted image. This is ASL, or arterial spin labeling technique. So this ASL, you should know, it measures only the cerebral blood flow, relative cerebral blood flow. It does not measure the cerebral blood volume. So the ASL has broadly three types. One is the pulsed ASL, and the other is the continuous ASL, the pseudo-continuous ASL, and sometimes it's the velocity selective ASL. The pseudo-continuous ASL is widely used because it can be used to quantify the cerebral blood flow. Continuous ASL has some advantages because it has a very good resolution. So now recently, as part of the research tools, we have the territorial ASL, which measures ASL perfusion relative to a specific vascular territory. So the main advantage is it can be used repeatedly, it is non-invasive, no need to give contrast, and as in the MRI, there is no radiation. The main disadvantage compared to the contrast perfusion is it may have, compared to the contrast, poor signal to noise ratio. So this is the third question. So you have a FLAIR image, T2 weighted image, and another image. So what are the findings? What is the sign? What could be the other causes? What is the diagnosis? And what is the specific study which is shown at the bottom below? So I think some of you would know the sign. What is the sign? You can be a bit loud. I hear only murmurs. You can be a bit loud. What is the sign? Okay, you see a lesion which is seen in the left temporal insular region, and it is hyperintense in T2. And you can see in the FLAIR it is partially suppressed to the peripheral rim of FLAIR hyperintensity. So this sign is known as the T2 FLAIR mismatch. So the T2 FLAIR mismatch was earlier considered to be specific for a certain type of glioma called as the IDH mutant glioma, or the isocitrate dehydrogenase mutant glioma. The mutant glioma has a good prognosis compared to the wild type. So what is this study? This is a dynamic T1 perfusion. The perfusion, you know, is of three types. One, it can be the non-contrast ASL perfusion. It can be the commonly used perfusion is the DSC, or the gradient-based perfusion, dynamic susceptibility perfusion. And this is the T1 perfusion, which is called as the permeability imaging. So this measures the permeability, and you get parameters which can be measured called as the K-trans or the VEP. So this is the lesion that was described, and this is the T2 FLAIR mismatch. So this is a mutant glioma, and that's a dynamic T1 perfusion. It is not a DSC perfusion study. So the other cause for the T2 FLAIR mismatch, which has been described, is in some other brain tumor. What is it? Anybody knows? Yeah? So is it described in a DNET, or in a disembryoblastic neuroepithelial tumor? So what is this T2 FLAIR mismatch? It is an appearance which is considered specific for the diffuse or the anaplastic astrocytoma. It's an IDH mutant, 1p19q non-codelated molecular status. So nowadays there is radiomix and glioma, radiomix and other tumors are known. So this has a better prognosis compared to the wild type. So the T2 FLAR mismatch has been observed also in other tumors like the DNET tumors. So it's just a table which differentiates the IDH mutant and the wild type, which may be useful for your exam. So the age, usually the mutant type is less than 40, younger age, this is more than 60 years, good prognosis, bad prognosis. Commonly the mutant is in a single lobe involving the frontal lobe predominance or the insula, the cerebellum. The wild type involves the frontotemporinsular type. The mutant type may be larger in type, the borders are well defined, whereas the wild type, the borders are ill defined. So it has a homogeneous signal with less contrast enhancement. The RCBV or the cerebral blood volumes may be low. The typical imaging biomarker in contrast to the wild type will be the T2 FLAR mismatch sign. In MR spectroscopy, a 2-hydroxyglutaric peak will be seen. And the molecular status 1p19q is non-codelated status. So these are multiple images having contrast images and the T2 weighted and the FLAR images. What are the leading questions when such an image is provided or when you encounter in MRI? What is the Stuck protocol? What is the diagnosis and what is this appearance known as? What could be the differential diagnosis and how do you differentiate both? So you know, when you see this, what are the leading questions you have to ask in history of surgery? Or you can see the post-operative defect. When you see an irregularly enhancing lesion with some necrotic components, which is seen here. So what is the Stuck protocol? Anybody knows? Yeah, it's after the you give the temozolomide, combination of temozolomide and radiotherapy. So what is these are further MR spectroscopy images. So what is the diagnosis? So the diagnosis is, this is a pseudo-progression and the appearance is known as the Swiss cheese appearance. The Stuck protocol is basically a combination of radiotherapy with temozolomide. The main differential diagnosis, you have to differentiate a true progression from a pseudo-progression. And the way to differentiate is, you can do either, the morphology is very important in MR, you can look at the T2 weighted images, the involvement of the corpus callosum, whether the extent of the lesion, whether it is involving outside the radiation port, and next is the perfusion weighted imaging and the contrast enhanced imaging. So when you look at the MR spectroscopy, in this patient, if you look here, within the necrotic core, you are seeing a large lactate peak with inverted doublet. And this is a multivoxel MR spectroscopy. And as you should know that you do a multivoxel to compare with the contralateral normal brain parenchyma. So if in the normal brain, you don't see a lactate peak. And the colon is about, you don't look at the peaks, you know, the Hunter's angle, you look at the integral values. So the integral value is around 0.25, and when you compare within the lesion, the peripheral irregular necrotic rim, you can see the integral values are relatively the same. So there is not much of increased colon integral value, although in many cases you may not get a good spectrum like this. So pseudo-progression is a transient phenomenon that can occur with either spontaneous improvement or stabilization. The temozolomide enhances the radiation response in the glioblastoma cells, and it causes disruption of the blood-brain barrier. FDG PET may not be, can also be used sometimes, but it's not very specific for the tumor tissue. So in true disease progression, you get increased colon integral values, not much of lactate, high relative cerebral blood volume, and low ADC values. In pseudo progression, you get lactate peak, as was seen in this patient. Colon and Na may not be having tremendous increase, and there is a low cerebral blood volume. So what sign is this, and what is the diagnosis? What will you do? Yeah. You can be a bit loud. You are telling the right answers. You can be a bit loud. So what is the sign? What sign is seen here? So this is a plain CT scan of the brain. So nowadays, I think most of the radiologists do not do the CT brain. The film is taken by the neurologist, and you do not spend much time on it, but you should know to identify certain conditions in CT brain. One of this is this. So what sign is this? What is the diagnosis, and what will you do next? So this is what is this? So it's a cord sign. So it indicates a cortical vein thrombosis or a dural sinus thrombosis. So looking at it, you have two options. Either you can do a CT venogram to look at the thrombus or the filling defect, and the MRIs can be done, or is it free, you can do an MRI, the MR venogram. And if you do an MR venogram, what are the difference between a TOF venogram and a phase contrast MR venogram? So this is a COT sign indicating of a cortical vein thrombosis. Either a CT venogram can be done or MR venogram. So the difference between the TOF and the phase contrast. Normally use a 2D time of flight for the venogram. 3D time of flight is used for the MR angiogram of the arteries of the circle of Willis. Routinely nowadays we use the phase contrast MR venogram because it offers some advantages. So what are the advantages? It can assess the anatomy in complex areas like the torcula, and it is velocity dependent. So you may not get the T1 contamination effects which can be seen in TOF venogram, which can mimic some vascular lesion. So T1 contamination effect is also reduced. So these are the corresponding MR images of the same patient, where you can see the focal area of blooming with the linear gradient blooming indicating a cortical vein thrombosis. So if you see a superficial cortical vein thrombosis in this location, what will you suspect? Which vein? Is it the labae or trollad or the venous angioma? Is it labae or trollad thrombosis, superior? Yeah, it's the vein of trollad thrombosis. So the vein of trollad is the superior anastomotic vein that is connecting the superior sagittal sinus and the superficial middle cerebral vein of Sylvius. So this is just to show you another case of hemorrhagic infarct with the venous thrombosis. The T1, you can see the hyperintense thrombosis, and the absent flow void in the FLAIR images. So what is the sequence? This is a very important sequence in the MR venogram, post-contrast sequence. Maybe one sequence that can be used to in all cases of CVT. This is a 3D gradient or an SPGR or an MP-RAGE sequence depending on the vendor. So this is a very important sequence where you can, even without the venogram, you can nicely see the filling defect in the veins. So this is the next question. Few images are provided, the sequences T2 weighted gradient, FLAIR, fat suppressed T1 and the ADC. So what is the finding in the sequences provided? What would be a diagnosis? What are the clues? So you can see there is a focal lesion with gradient blooming which is seen with a peripheral hypointensity rim and some perilesional edema is noted. Post-contrast subtracted images showing only a faint rim enhancement. Some low ADC values are noted. These are the FLAIR images, fat suppressed T1, these are hyperintense. These are the findings. What would be a diagnosis? Anybody? Okay, this is a clue to the correct diagnosis is this. This is the peripheral hyperintense rim which is noted around the lesion. So this is perilesional T1 hyperintense rim. And this is a clue to the diagnosis. This can be seen either in two conditions. Earlier, a few articles described it to be seen in case of cavernoma. Okay, so this is a perilesional T1. It can also be seen in metastatic melanoma. So this is the perilesional hyperintensity on T1 weighted, and it can be seen in metastatic melanoma, but it's never seen with gliomas. So that's it's an article which was published earlier. So as you know, the cavernous malformations can be classified by the Zebrabansky into 4 types. Type 1, which is subacute hemorrhage that we saw here. Typical cavernomas have the popcorn ball appearance. Type 3 will be the chronic hemorrhage, and type 4 will be the patchy multiple microbleeds. So what are the findings? What is it called and what are the causes? So what is it called? Anybody knows? Okay, I hear some voices saying encephalocele. Okay, this is, you can see where there's a focal herniation of the temporal lobe through a defect in the temporal bone into the middle ear. So this is called as fungus cerebri. So what are the causes? It can be due to post-operative causes And the main complication is patient can develop an autogenic meningitis. So this is a defect in the tegmentum pani with herniation of the temporal lobe in the right side. The major cause is post-op secondary to mastodectomy. It can also be seen after mastoiditis, temporal lobe fractures, prior temporal lobe fractures, or a spontaneous herniation. So fungus cerebri by definition is the protrusion of the brain and the dura after the cranial cavity into the mastoid and middle ear. 40-year-old with severe headache, T1 weighted sagittal, T2 axial, flare coronal images, diffusion weighted images showing low ADC, and MR spectroscopy showing a lipid peak. So these are added bonus images for your reference, which you can see. So the questions are, what are the findings? You have to describe the findings. What would be the differential diagnosis? What may be the primary diagnosis? And if you know the primary diagnosis, what are the ectopic sites of this lesion? And what is the significance of the low ADC values? What is the peak that is elevated? And what are the causes? So the findings are, you see a relatively well circumscribed lesion in the suprasellar region involving the third ventricle with significantly low ADC values with peripheral high pointance gradient blooming appearing relatively hyperintense in T1 weighted images. So these are the findings. The differential diagnosis for this suprasellar lesion involving the third ventricle based on the findings could be either an epidermoid cyst, but not necessarily because it is hyperintense, the DD. Based on the CT, maybe a hemorrhage. So what are the other differential diagnoses? So the basic, these are the, it could be a craniopharyngioma, rarely an abscess with vascularized wall. The other common DDs for it can be a macroadenoma, which can be ruled out because the cell is involved, suprasellar germinomas or epidermoids. The primary diagnosis, this was an intraventricular papillary craniopharyngioma, which is quite a rare diagnosis, and we published it some years back. And the ectopic sites of craniopharyngioma, maybe they are in the nasopharynx or the sphenoid, pineal regions, even cerebellopontine angle, and the third ventricle. What does the low ADC values within the lesion reflect? Generally in brain tumors, you must remember that the low ADC values reflect the friability of the lesion. So tumors with high cellularity may show restricted diffusion. These are not friable, very difficult to crack open, and the consistency can be assessed with the ADC. And based on the tumor consistency, the operating time is influenced. So friable tumors can be easily resected, while the harder tumors need a careful dissection. The peak that is elevated is the lipid peak, which can be seen in craniopharyngiomas, which reflects the high amounts of cholesterol. So what are the sequences provided and the findings here? And what is the diagnosis? What are the differentials that can be considered? What can it be due to? So what is the sequence? It's an important part of the seizure protocol. So this is a 3D SPGR sequence, and what could be the diagnosis? And what would you consider as a differential diagnosis? So if you see the findings, you find polymicrogyria in this region. There is a CSF cleft which is seen leading on to the frontal horns. So what is the diagnosis? And what can it be due to? See, these are some other images. T2 weighted image which is seen here, and the flare image that is seen, this is just a 3D reconstructed image. You can just trace it using a curved multiplanar image. So this is the MP-right sequence, as some of you told. So basically there is a polymicrogyria with a large CSF cleft which is extending to the subepidermal region. So this is actually a closed lip schizencephaly with polymicrogyria. The differentials, maybe it can be a transmantle cortical heterotopia or a transmantle cortical dysplasia. The embryology behind it is abnormal post-migrational development. So basically, schizencephaly and polymicrogyria have an association due to the impaired cortical development at the post-migration level. They basically arise due to hyperperfusion and severe insults may result in clefts lined by polymicrogyria. So this is just C. cephali, you should remember, as three types. One is type 1 transmantle column of abnormal gray matter with no evidence of a CSF cleft, which can be otherwise called as a transmantle heterotopias. C. cephali type 2 is the CSF cleft which abuts the lines of the abnormal gray matter. The type 3 C. cephali is a cleft is present, but there is non-abutting lips of the abnormal gray matter. So these are the examples. You can see this is the, there is no cleft. This can be called as a transmantle heterotopia. And this is the CSF cleft is seen as the open lip type or the type 3 C. cephali. So this is an example of a transmantle columnar heterotopia where you can see gray matter extending from the cortex towards the subepidermal region. In contrast, in dysplasia, which is otherwise called as the bottom of the sulcus dysplasia, this abnormal signal extends from the periphery with a hyperintense signal in the FLAR image in contrast to the transmantle heterotopia. So that is the difference between the transmantle dysplasias and the transmantle heterotopia. And this is called as the transmantle sign, which can be seen in focal cortical dysplasia. So this is the next question. So what is the sequence? Anybody knows the sequence? Have you seen the sequence earlier? And what are its applications? What? 3D, somebody said. Proton density. Okay, it seems to be the proton density sequence. Okay. So you can see this, there is a difference between this. Both are a pair images. Okay, this is both. And then this has been some measurement is shown here to calculate a particular ratio. So that's the clue to the diagnosis. This is a magnetization transfer sequence. So this is without magnetization transfer, this is with magnetization transfer. So the main use of magnetization transfer is it enhances the contrast and the gray-white differentiation. So basically it can be used mainly in applications to evaluation of granulomatous lesions and for the evaluation of demyelination in multiple sclerosis. And to differentiate tuberculoma and neurocysticercosis, you can use the MT ratios where typically tuberculomas may have low MTRs ratio less than 0.14, and the ratio that is seen is the magnetization transfer ratio. So you can see nicely the difference in the contrast difference between without magnetization and with magnetization transfer sequence. So basically it is a T1 weighted sequence where you use a TR of about 1000 in 1.5 Tesla MR, and it provides more of contrast augmentation and tissue characterization. So it enhances the lesion load depiction in multiple sclerosis. And even in post-contrast, it's helpful in certain conditions, especially in metastasis. It can be used when it is lesions are inconspicuous in fat suppressed T1, which we use routinely. Even T2 invisible tuberculomas can be better visualized in magnetization transfer images. And what is the magnetization transfer ratio? This the formula is magnetization value without MT minus with MT into 100 divided by the value M0, which is magnetization transfer without applying transfer images. What is this finding? What are the types? What is the significance? How do you differentiate from chronic lacunar infarcts? And some diseases associated with above finding. So what is this? I think most of you will know. What is this? What is it? Okay, these are prominent Verkov-Robin spaces. So based on the location, it can be of 4 types. It can be involving the area supplied by the lenticulostriate branches in the basal ganglia, supplied by the perforating medullary arteries where they enter the cortical gray matter. They can involve the deep gray matter involving the midbrain and the anterior temporal lobe. So these have been identified as a marker of microvascular disease. It can also be seen with Parkinson's and Alzheimer's disease. So basically the lacunar infarcts have a gliotic rim in contrast to Verkov-Robin spaces, and these have been found to be associated with in cryptococcosis in retroviral positive patients, mucopolysaccharidosis, and even CADASIL and cerebral amyloid angiopathy. What is this sign? Why does it occur? what would be the diagnosis and what would you do next and why? So what is this sign? Yeah, I heard many whispers and murmurs, but somebody can speak out loudly. What is this sign? Yeah, this is a CSF flow void sign. So this occurs due to the high velocity across the CSF aqueduct. And what would be a diagnosis when you see these pair of images? This is a non-bond pressure hydrocephalus. You can see the dilated ventricles with ventriculosulcal disproportion. So yeah, you can do a CSF flow, phase contrast CSF flow velocity imaging next. And typically you can see the exaggerated CSF flow void across the aqueduct in the T2-weighted axial images, which you may not see in all cases, only in cases with increased velocity in the aqueduct. So basically the CSF flow velocity imaging, CSF flow velocity may be more than 12 centimeters per second in PH patients. And the stroke volume depends upon the machine that is used, whether it's 1.5 Tesla or 3 Tesla, but earlier by Bradley, and it has been said more than 42 microliter, but that's not a strict rule. It depends upon the machine used and our population. So basically the CSF flow void sign occurs because the normal brain expands outward. While it expanding outward, it compresses the cortical veins and expands the inward, thereby compressing the lateral ventricles. So this results in extraventricular obstructive hydrocephalus when the brain is expanded against the calvarium. So during systole, all the cerebral expansion is directed towards compressing the third and lateral ventricles. So basically the CSF flow velocity imaging is used to assess the stroke volume and peak velocities and guide for shunting. So in NPH patients, you may also identify this CSF flow artifacts in the third ventricle. So that's the CSF flow velocity phase contrast sagittal image, that is the flow visualization. Patient with back pain, what is this sign? What is the cause? What is the pitfall of this finding? So this is of very great practical importance that you have to know to identify. So anybody knows what is this sign? So what is the cause for this? If you know the sign, you know the cause. Okay, anybody knows what would be the diagnosis? Loudly. Okay, this is called the redundant nerve root sign or redundant nerve root appearance. You can see multiple elongated tortuous nerve roots which are seen here, and this basically occurs due to the severe spinal canal compromise, and you can see clumping of the cardiac vena rootlets. And to identify the redundant nerve root, you have to look at the axial images. The main pitfall is that this should not be confused with arachnoiditis. So what is the redundant nerve root sign? You can see the nerve roots. Normally if you draw a line, you do not see the nerve roots anterior to this. When you see nerve roots anterior in the thecal sac, it indicates this is due to the redundant nerve roots, which can be due to severe spinal canal compromise and cardiac vena rootlet compacting. So this is a patient with chronic lumbar degenerative canal stenosis and must not be confused with arachnoiditis. So generally the nerve root sediment to the dorsal part of the dural sac, that is called as a negative sedimentation sign. There are only two exceptions to this when the nerve roots leave the dural sac, one segmental level below the stenosis. Whenever you see nerve roots in the ventral part of the dural sac, then the sedimentation sign is said to be positive. So this is an example from the article where you can see this the normal nerve roots which is seen in the dorsal part of the thecal sac. Whenever nerve roots are seen anteriorly in at least one axial MR image above or below, then this is called as the positive nerve root sedimentation sign. So this is a redundant nerve root in patients with chronic lumbar canal stenosis, and this complication arises due to the continuous and chronic compressive forces on the nerve roots within the canal. So that is the article which has been describing redundant nerve root. So this is the last question. What are the findings seen here? What are the differential diagnosis? What would be the most likely final diagnosis, and how do you differentiate these? So the finding is you see a long segment intramedullary lesion in the dorsal spinal cord, cervicodorsal cord with mild cord expansion. Contrast shows relatively homogeneous enhancement. This is the spinal MR spectroscopy that is done that shows a lipid peak. So what will be the most likely diagnosis? Okay, anyone? So this is the differential diagnosis can be spinal cord tumors, or it could be spinal cord granulomatous lesions. Spinal cord tumors will have more of cord expansion, more of inhomogeneity. This is relatively well defined, minimal cord expansion and a homogeneous smooth enhancement. Lipid peak noted in spinal MR spectroscopy. So this is was proved to be a spinal intramedullary tuberculoma. So the main differential diagnosis is the spinal cord tumors. So I have told you the findings, and LETM can occur also. So this was proved to be a spinal intramedullary tuberculoma, and in LETM the cord expansion is minimal with a patchy enhancement. So this is the MR spectroscopy, spinal MR spectroscopy, and the spinal diffusion irradiated imaging that showed the low ADC values. And in DTI there was no cord disruption, there was just a displacement with edematous cords. And pathology also showed to be caseation was present and proved to be an intramedullary tuberculoma, and this was also published as part of our publications in spinal 3T MR spectroscopy. Thank you all for patiently listening, and thank you for the opportunity.
Thank you, sir, for the wonderfully compiled informative session. I now request our beloved HOD, Professor Dr. Devi Meenal ma'am, to felicitate Professor Dr. Babu Peter sir.